Hi, good evening.
Yeah.
Now you can hear me?
Yeah, I can. I can. I'll
Okay,
just
so
switch
you
on
can.
the.
I think Dr. Kiran was supposed to be a moderator. I don't know.
Okay,
So let me see. I'll just try and call her.
sure.
We can wait for 2, 3 minutes. If she does not join, then we can start. I think we are waiting for 2 minutes more. She does not come, then we can start. Okay, Sharmila, I think you can start. I think she's here. Okay, so our moderator is here now. Over to you, Kiran. Can you hear me?
Yeah, yeah. Hi, good evening, everybody. I'm so sorry, to
Please
join late.
put on your video on kar do, please.
1 minute. What is happening? Hello, good evening, everybody. I'm so sorry that I'm joining late, but it is a pleasure on my behalf to welcome Dr. Sharmila Tulpule. And I think I've been chasing this beautiful orthopedic surgeon who is an internationally recognized American board certified regenerative medicine specialist with over 3 decades of experience in MSK care. And she is the founder and director of Orthobiologics Biotech Private Limited and Orthobiologics Clinic, established to provide patients with unbiased orthopedic diagnosis and a comprehensive discussion of both surgical and non surgical treatment, including the latest evidence based orthobiological and regenerative therapies. She is currently practices in Madhubala Health and Medcare Hospital in Dubai and Orthobiologics Clinic, Mumbai, India, and divides her time between these two countries. One of the few practicing female orthopedic surgeon in UAE, GCC, and India, Dr. Tulpul has extensive expertise in orthopedic arthroscopic surgery, sports injuries, ultrasound guided orthobiologic interventions, and regenerative medicine. Her passion for orthobiologics evolved from her commitment to minimally invasive treatment that maximize healing while minimizing the need for surgery. And there are so many things, like she's being a gold medalist in general surgery. Following her postgraduate training, she refined her surgical skills under some India's most respected orthopedic and arthroscopic surgeons before serving as a lecturer, head of department, trauma surgeon, and consultant at leading institutions in India. She also underwent advanced arthroscopic training in France before establishing a distinguished orthopedic career in Dubai. And now, like, she's also like holding that region conference, which is on the 5th and the 6th of September in Mumbai. And my when I saw this, when I first met Sharmila in Sorcon at Kolkata, I was really very much impressed by her, because even at SOR, like, we are thinking of many ways where we can preserve the joint and can give some relief to the patients in catching them very early on, so that we can do justice with their joint. So, not wasting much time already, like, so much has passed. I hand over the mic to stage is all yours, Charmila. You can go ahead with your presentation.
Thank you so much for such a kind and lovely introduction. Okay. Uh, I was just waiting for this opportunity to address everybody at SORCON, and I'm so grateful that all are here now. I'll just start sharing my sharing the yeah.
So I met the team over there because we attended the workshop which has been done by doctors at Sorcon, and your name was flashed over there because of this region, and they are
Ah,
going to
okay.
present the BMAC
Yeah,
guidelines which
yeah,
they have been made.
yeah. So yeah, great to meet you all here. So I'll just start my presentation actually. Okay, these are my disclosures and none are relevant today. We'll just discuss. I'm sure all of you know osteoarthritis, but we'll just discuss why is it so difficult to really treat osteoarthritis at the root of it. While there has been a total shift in the treatment of rheumatoid arthritis and disease modified drugs, there has been not much on the front of osteoarthritis. And we'll just be discussing what regenerative medicine can do in this, or orthobiological treatments can do in this. So, actually, this is uh, this was predicted in 2003 in Time magazine that there is an arthritis epidemic coming on. Following which, there was another issue that they did in 2024, which was chronic inflammation as a secret killer, and how chronic inflammation is at the root of all the chronic diseases that we are experiencing today. And 25 years on, it has come all true. So what is the present status? It has really turned into an epidemic. Over 180 million people in India are affected. I'm going to be India centric today, are affected by osteoarthritis. It's 17% of the world population. Our population is 17% of the world population, but OA sufferers are 39% of Indian population. Okay, so though our population is less, our OA load is much, much more than the world. So if we can stop and reverse the lesions in the beginning, and we all have been actually trying to do that. So what are the present options, treatment options for osteoarthritic knee? NSAIDs, as you all know, physiotherapy, viscosupplementation, lifestyle modification, intra-articular steroids, and directly surgery. If nothing of this is working and the disease is progressively worsening, we land up with surgery. And actually, to think of it, none of these treatments has disease modifying capacity, actually, in the true sense. Corticosteroids for joint and tendinopathies, there have been total 43 papers which are published till now. Uh, and it has been proven beyond doubt that local anesthetic and steroids are chondrotoxic. There is level 1 evidence which was published in 2019 also. Then there is this publication of very strong analysis, 60-year analysis, included 24,400 patients, very strong paper, of which 9,000 were steroids or and 15,000 plus were PRP, including 119 RCTs. So this is the strongest paper to give evidence in volume that PRP evidence or regenerative medicine evidence has long back crossed the evidence for steroid working for arthritis. So think of it, why is it difficult to treat osteoarthritis? When you say osteoarthritis, I'm talking of an average orthopedic surgeon. What we tell the patient is that your cartilage is degenerating and that's your osteoarthritis, right? But what we realize it now, that understanding of the disease took too long. We focused on cartilage lesions, which are actually the effect of the disease and they're not the driver of the disease. And when we are talking of effect of the disease and we are only focusing on that, obviously we are missing the bus somewhere. So what we know now is that osteoarthritis is not a wear and tear disease. It's a chronic low-grade inflammation, which is the driver of the disease and not the cartilage degeneration, which is the effect of the disease. There is a strong autoimmune element also. Local and systemic inflammation both are equally important, and all the while we were only treating the local pathology and not completely ignoring this, general pathology, the systemic one. Hormonal and metabolic element is crucial. Again, I cannot overemphasize this. Why is this sudden epidemic of osteoarthritis happening in perimenopausal women? There is very strong link with hormones, and that's what is crucial. So OA is not one disease, but it is clinical endpoint of multiple diseases. So when we say what is the pathophysiology of osteoarthritis, in relation to what we want to treat in orthopedic, I would say there is total disbalance between pro-inflammatory cytokines and anti-inflammatory cytokines. And another thing which is very interesting, what was found that there is reduced gelsolin level. So gelsolin is a protein which is found in plasma as well as synovial fluid, and that gets reduced in osteoarthritis and also very surprisingly in rheumatoid arthritis. There was a lot of work which has happened on this gelsolin protein even in 1970 and early 1980. We'll come to that. So going on to what are the causes and what is the source of pain in osteoarthritis, two are different things. What is the cause of pain? Cause of pain is inflammation. That's the most important cause. We can very, very easily see that if some patients have very bad x-rays, grade 4, degenerated, almost bone on bone, but they are very comfortable. And some patients in whom it has just started or just even the joint space is very much preserved still and they are in extreme pain. So the cause of pain clearly is not the degenerated cartilage, but it's inflammation. And this inflammation is accompanied with bone marrow lesions or bone marrow edema in subchondral region. That's extremely important. Ischemia, microthrombosis, neurogenic pain, and microfractures. Okay, so these are all the additional things which cause pain. What will be the source of pain? Synovium. Subchondral bone is a very, very important source of pain. Whenever there is edema in or bone marrow edema in subchondral region, there will be pain always. Capsule, meniscus, ligament, and fat pad. So coming to regenerative treatments and whether they can do something or alter the disease progression or disease whole trajectory of the disease, let's see. So in regenerative treatments, the targets should be local inflammation, systemic chronic inflammation as we saw. We should be able to target the immune element also in the osteoarthritic disease. And then there is regenerative effect on the cartilage. That's not the primary aim. Primary aim should be to reduce local inflammation, systemic inflammation, modify the immune element, and then have regenerative effect on the cartilage. What are the supportive treatments? They should be hormonal, so we should not be neglecting hormones. And in fact, I've seen so many patients who are put on hormonal therapies doing exceedingly well with the treatments that we give. So please, I would really put a lot of stress on hormonal treatment. Physical, muscle strength or muscle health, bone health, and mechanical. Mechanical supportive treatment is going to be where there is already mechanical disruption, that is varus or FFD, that is fixed flexion deformity or range of movement restricted, so on and so forth. So orthobiologics is a new and fast developing field which uses biological elements which are mostly autologous to treat orthopedic problems. What are these biological elements? There are lots. So what you should know, there are lots of treatments now available, and it's very important to know when to use them, what to use amongst all these orthobiologics, how to use them exactly, and I think this is the most important, when not to use it. So when to use after exhausting all traditional treatments. This is not the first line of treatment, and I wouldn't suggest jumping onto orthobiological treatment just because a knee pain comes to us. So you do obviously treat the basics. You do treat it with basic anti-inflammatory and physiotherapy, lifestyle modification, and then patient comes back to you saying that this is not working. Then we have to think of the next line of treatment. Second, when to use. When mechanical malalignment needs to be corrected before treating the biology. That's very important. So if there is a gross varus, whatever we put inside the joint is not going to work for long term. It will work short term, it will reduce the inflammation, but it will be relapsing again and again because the mechanics are completely changed. So we need to, in that case, do an osteotomy to straighten it and then put the biologics to improve the joint. That should be the order. Again, I would say when to use, which grades. Grade 1 and 2, of course, we can use and we should be using. Moderate grade of osteoarthritis or grade 3 KL classification, we can. But grade 4, that is late grade of OA, wherein there are deformities, there is stiffness, then you should be extremely cautious because the mechanics needs to be addressed first. When not to use. This is the most important slide I generally tell all my friends that in orthopedics. One, you should legally check whether this treatment is allowed to be done in your country or not. If there is not enough training, that's a red flag. It's not just, somebody hands you over an injection and you're injecting. It's much more than that. And your facility having license or no. Now, this is more relevant in the foreign countries or in Dubai or UAE, where we need to have license for the clinic or center where we are working. When not to use mechanical malalignment. If there is a mechanical malalignment, it needs to be corrected before doing biologics. Pre-operative workup, like any other, is extremely important because we pick up so many things when we do that pre-op workup. Not as a first line of treatment and only trying all the other conservative treatment. So this is not one fancy new toy that we have got. It has science and we need to really get into the depth of it. So going to what orthobiologics, what are the available ones? Gene therapy is experimental. As of now, it is in experimental stage and we're not discussing it. So orthobiologics very broadly can be cellular and acellular. Cellular could be PRP. Again, PRP has cells. Platelets are cells, okay, and there will be leukocytes also. So it could be leukocyte poor or leukocyte rich. And then there are stem cells. We don't call it stem cells anymore, but for a very basic understanding purpose, I'm saying stem cells, okay? So they could be adult or embryonic or umbilical cord. Adult stem cells could be BMAC, that is bone marrow aspirate concentrate. Adipose stem cells, which are freshly harvested like micronized fat. And there could be allogenic stem cells, which are from some donor, and then you're taking it, culturing it, and then putting it into the body of the patient. Acellular could be autologous conditioned serum. In various ways, you condition the blood and then make serum out of it, then filter it and get that to be injected. There could be alpha macroglobulins, which are the proteins, larger proteins in plasma. And there could be cold induced ACS or autologous conditioned serum. Most commonly used in orthopedics are PRP based ones, of PRP, PRF, or growth factor, or leukocyte rich and leukocyte poor in PRP. There could be ACS that we use frequently, that is autologous conditioned serum, which has glass beads, or gold induced. And there is BMAC and adipose cells, fresh or cultured. Looking at regenerative potential, which ones of these have real true regenerative potential? Not PRP, not ACS. What we have seen is that cell therapies like adipose or BMAC do have great regenerative potential. And we've also seen that gold-induced cytokine therapy also has very good regenerative potential. The effects of PRP and MSCs or cell-based therapies are a bit different. PRP will be mainly anti-inflammatory, tissue repair, and angiogenesis. That's the main purpose. But MSC or cell-based effect have tissue regeneration as a main effect, and with progenitor cells and which have terminal differentiation. Also, immune modulation could be one of the very strong effects of MSCs. How are we going to target the disease? Local disease and systemic disease. Okay, so local, we can target intra-articular by doing intra-articular injection of orthobiological element, peri-articular and subchondral and tendinous also. Okay, so if there is a pes anserinus bursa or tendon which is inflamed, we could inject it there also. In systemic, we are using intravenous gold-induced cytokine therapy, which has given us extremely good systemic anti-inflammatory as well as immune modifier effect. We very strongly advocate doing all these procedures only image guided and not doing blind landmark-based injections. I'm sure all of you know about PRP, so I'm just going to go through very basics of it. Now, the recent definition of PRP has gone to 7 or more times basal platelet count is required for MSK specifically or osteoarthritis, because cartilage is such a tough tissue for an effective result. This is a whole list of growth factors which are there in PRP. All of them have very specific functions, and if we get into the depth of it, we will be able to actually modulate what function are we looking at. So if I am treating a chronic wound or chronic ulcer, the way I will be processing the PRP for angiogenesis and epithelial growth factor, so that will be different than what we do for an osteoarthritic knee. Effects increases growth factors levels. That's the most important effect of PRP. It provides a scaffold or matrix. It has strong anti-inflammatory and antimicrobial properties. So you will find that PRP injections generally you will very rarely see an infection happening there because it has got antimicrobial properties also. It accelerates the regeneration and healing, but it's not in itself, it is not a regenerative procedure. So if yours is a hospital-based practice and yours is a clinic-based practice, the way you do or process the PRP will be different. In hospital-based practice, you have the luxury of making the PRP in your lab or in your blood bank. So that's a manual PRP that you're doing. You'll have to make your own protocols. You'll need a biosafety cabinet for the aseptic precautions. There should be a cell counter and there should be a separate procedure room or even an OT. In clinic-based practice, it's a bit different. There should be a separate procedure room for sure. but you can use, or generally we advise to use ready kits because they are closed systems and then you are not risking any external infection there. Test the kits before using, that's extremely important. Check all the counts before standardizing, that's again very critical. The blood draw amount, your centrifuges, everything has to be standardized. There has to be strict asepsis and strict protocols. The moment your protocols are in place and are being very strictly followed, then I think the results very rarely go wrong. That's what we have seen. What is an ideal PRP for orthobiological use? This is, after doing hundreds and thousands of PRP, this is a conclusion that you need 60 ml of blood draw for one big joint. And you need to actually reduce it or concentrate it to around 6 ml of PRP. Then what you get is between 9 to 10 billion platelets, and that is the most effective dose of platelets. And that's a total dose of platelets. It's not per ml. Okay, so it's a total dose of platelets, which will probably become 9 or 10 billion, even if your system or your kit is not great or not the best of it. Still, if you're taking more blood and your basal platelet count is around 2.5-ish, then you should get to 9 to 10 billion platelets. Coming to bone marrow aspirate concentrate, this is the endosteal region, and most regenerative cells are located in this endosteal region. So you go inside with a bone marrow needle, you take out in different directions, these cells are sucked out, and then they are actually centrifuged and taken as a pellet. So these are the factors which are there in bone marrow, and all of them have different functions, as I said. Okay, so immune modulation, apoptosis, chemotaxis, fibrosis, proliferation, and angiogenesis. So these are the MSCs which have all these effects, and we have lots of literature on bone marrow aspirate concentrate. This is the oldest of the methods which are used as stem cell therapy. We have Dr. Philippe Hernigue from France, who has actually published 15-year follow-up following bone marrow aspirate concentrate injections for osteoarthritis with extremely low rate of conversion into total knee replacement, which this paper has been recently published. So it's a great one. And we in region conference are going to actually come out with first ever
But
bone
you
marrow
please mute
aspirate.
yourself if somebody is talking in between. Please mute yourself.
So we are going to come out with bone marrow aspirate concentrate BMAC guidelines. This is the first time in world that we are coming out with such guidelines, and we have got all the international leaders on board for making these guidelines. We are almost on the verge of publishing it, and we'll unveil it in our region conference. Last year, we unveiled PRP guidelines, again, first time in the world, and they've been extremely well received. It has been endorsed by American Board of Regenerative Medicine and whole lot of other bodies also. Coming to another very interesting and my favorite source of stem cells, autologous stem cells, is adipose tissue. Adipose tissue is a mixture of lots of cells and they are extremely regenerative. It's much more in number and quality than bone marrow. So if we analyze adipose regenerative cell matrix, the endothelial and progenitor cells or pericytes are 7%. So this is the main chunk of regenerative cells. Then there are tissue macrophages, which are M2 type and not M1. Stem cells are, or MSCs are 1 to 4%, which are less, but as compared to bone marrow, they're still much more. Effects, again, they secrete growth factors, cytokines, regenerate the tissue, they prevent senescence, and they reduce inflammation. They also have huge immune element modification potential in them. This is how we are right now processing our MFAT. Yeah, so this is how we harvest the fat. Then this is the processor in which the fat is put. It is washed 2 times. Once it is washed and it is put in the centrifuge, we remove all the waste fluid once it is done. Again it is put for the second centrifuge, and then the whole of the waste fluid is removed. This is the second time that we are removing, and we are ready to have our purified micronized fat, which will be mixed with a little bit or 20% of PRP for various reasons. And that's the final MFAT to be injected. So we always do it under ultrasound guidance. If we compare adipose stem cells versus BMAC, I would say we prefer adipose for all the cartilage regeneration. For bony, where we need osteogenic potential and not the cartilage potential, like osteogenic potential, wherein it is required in AVN of the hip, we or non-union or delayed union, we prefer using BMAC. But rest of the things, I think adipose scores over BMAC with huge margin. Adipose stem cells are huge amount. The inbuilt scaffold, you're getting a live bioscaffold when you're doing it. It has more chondrogenic potential. It can be used for osteoarthritis and tendinopathies. The evidence is developing and it's not already there. Biocomposite therapies are the ones in which we combine two biological elements. So generally, biocomposite therapies are, one is cellular element, the other is blood component. So here what we did is adipose, we mixed adipose with PRP. So one is cell element, other is blood element. And that is supposed to, or what we've seen is that the effect of MSCs is much more or better when we are getting the growth factors from PRP. Again, I'll just introduce you to a great favorite therapy of mine, which is gold-induced cytokines. Right now, it's not available in India, but I'm just introducing you to it. Okay? It's kind of breakthrough in regenerative medicine. The fundamental thing is blood is incubated with gold particles for 24 hours. It is centrifuged, next day filtered, and then injected. So the concept is that blood, when it is incubated with gold particles, it actually reacts with monocytes, T cells, which release in turn cytokines, anti-inflammatory factor, and gelsolin that we mentioned, which is reduced in osteoarthritis and rheumatoid arthritis. Remember that slide? And various other factors also. Gold and blood cells are completely filtered out. So what we get is an acellular serum. When we've analyzed what is there exactly in ACS, gold-induced ACS, what we found that gelsolin is increased by almost more than 10 times. All the other anti-inflammatory cytokines are also increased, but what is more interesting is granulocyte colony stimulating factor and SCGF beta, hematopoietic stem cell growth factor. Now, these are the factors which are responsible for mobilizing the stem cells from their niche and then homing them where they are necessary. And look at how much it is increased. This is 6 is as basal and 1890. So this is absolute phenomenal increase in these two, and that's why the regenerative potential with gold-induced cytokines has been found to be very, very high. What is this gelsolin? Okay, so it has got trophic or positive effects on most of the systems of body, right from neurological system, cellular level, mitochondria, reducing senescence, that's why anti-aging effects, chondroprotective effects, so on and so forth. Procedure is very simple. We collect blood, we incubate it for 24 hours, then centrifuge it, filter it, and then it is ready to be injected. When we actually compared ACS, a normal ACS, which is when we incubate blood with glass beads, many medical grade glass beads, it's a very highly anti-inflammatory serum that we produce. Then we compared it with gold-induced and then PRP. What we found that only gelsolin is only raised in gold-induced and none other. Uh, when we compare IL-1 reverse antagonist, which is the most anti-inflammatory cytokine present, it is there very high in ACS, it is there high in gold-induced, but it is also there in PRP. In PRP, sometimes IL-1 beta is also there, and that could be the reason for flare. And of course, these two growth factors that I mentioned. So, is there any evidence to what we are saying that all these things work in osteoarthritis? Let's go through the evidence. So, this is a chart of PRP level 1 evidence. I'm always asked, is there any evidence? So, all the orthopedic conferences I'm asked that, sometimes people say that this is working, sometimes it says that it is not working. Do you even have an objective evidence? And so, you should just show them this chart. This is a tabulation form of total 180. So when you say level of evidence grade 1 or level 1, these are randomized controlled trials. So 180 RCTs for PRP done till 2026 April, out of which 84%, that is 151, showed very positive results. 29 were negative. 15 out of this had subpar platelet count. So why were they negative? Because the platelet count, which we actually now know should be there, was not there. And that's why it was not reaching that level of effectivity that we want. The concept is very simple. Say somebody has fever and you're supposed to give say 1,000 milligram of paracetamol, and you end up giving 200 mg of paracetamol to an adult who is 80 kg weight. It's not going to act, right? Same concept kind of works here, that the optimum dose we didn't know till probably 3 years back. And that's where, PRP was having a controversial evidence. But now it's very clear that we need minimum 5.5 billion platelet as an effective dose for any large joint osteoarthritis. For knee osteoarthritis only, there were 61 positive RCTs, only 5 were negative. So this is very, very strong evidence, I would say. This is the thing I was talking about. Platelet dose in PRP has been published in the most respected and very high impact factor journals like arthroscopy and so on. All of them have concluded that minimum absolute platelet dose is 5 or 5.5 billion as an effective dose. These are all the MSC, that is BMAC RCTs. There was only one in 1997, and look at the evidence now, it is huge. Similar with adipose stem cells, in 2011, there was only one study, and now from 2020 till now, there are 55 and more are being added, at least in 2026, I have yet to count. Our own research paper we published in 2022, quite a strong paper, wherein we actually did a biocomposite therapy of MFAT, that is micronized fat. We combined it with BMAC and we injected it. Now I think it is close to 5 years being completed, and we are going back and checking the patients. This was a 2-year follow-up that we had published. It was in scale grade 3 and 4, total 302 patients. Actually, the study had 400 patients, but we could, at 2 years, we could just go back to 302. And we had very, very encouraging results in this. Lots of research published also in Goldic, IV Goldic for chronic allergies and autoimmune diseases. I'm sure people would be interested in that. Goldic in lumbar canal stenosis, again, we are having extremely encouraging results for that. We are having extremely encouraging results in long COVID as well. This is our published research in Goldic. Just sharing a few pictures with you so that it just becomes more clear what we are talking about. So this was a 53-year-old female, 52, with grade 4 chondromalacia patella. If you can see here, there's a lot of subchondral edema. There is already a bone cyst, subchondral bone cyst, and there is grade 4 chondral lesions at multiple places. This is at 3 year post Goldic therapy, literally, and this was the same MRI, same radiologist. So we couldn't, just to keep the uniformity in the investigation. Complete healing of the cartilage, complete healing of subchondral lesion also. So it was a phenomenal result. Similarly, here also there was a little bit of subchondral edema, but as you can see, it was like full thickness chondral defects at multiple places. And this was at 3 years that complete regeneration of the cartilage happened. This was ADSC 1 year. ADSC is adipose stem cells in 39-year-old male. This was complete chondral defect here, which started filling up at 1 year. Generally, it takes about 2 years for the MRI to pick up those changes and thickness in the cartilage. This was a 32-year-old male with treated with BMAC, 1.2 year follow-up. Can you see here? Okay, it is a very bad subchondral edema, again with subchondral cyst and break in the cartilage. At 1.2 year, there is remarkable recovery, almost healing. I'm sure that it will be much better at 2 and 3 years. This was another adipose MSCs wherein there was almost full thickness cartilage defect, and it was a large defect. It was treated with adipose MSCs, and this is showing coming back of the cartilage, but not fully still. This is generally not indicated. I generally would be going in for surgery, but patient's insistence, this was done as BMAC with PRP, and this was PRP 5 months later. This is 2.4 year follow-up. You can see the horrible defect here. Wait, medial condyle, it's a big defect, and you can see here that the defect is healed. There is a thin layer of cartilage also which is seen, and with time it will just fill up. So the talk is osteoarthritis, I would just want you to see a few more things. Chronic Achilles tendinitis, 55-year-old golfer. This was for 2 year follow-up. So this was a very bad Achilles tendinitis, insertional. She had given up her professional career of golf and tried everything. Nothing was working, and we treated her with ACS, and this is the result at 2 years. Absolutely complete recovery, and even her MRIs, wherein there was completely altered signals, showed full healing at 2 years. This is another very interesting case of polyarticular rheumatoid arthritis, 78-year female. She was not responding to any of the routine DMARDs. She didn't tolerate biologics. She was very weak. She had multiple systemic issues. And so when she came, it was a tough case too. And she was literally carried in hands to us. And we treated her both knees as well as we did IV gold-induced cytokines in her. And this is how she was at 6 months. Complete recovery. She started walking, and we've treated quite a few cases like this. This is just another interesting case of lupus erythematosus. Again, we had done IV gold-induced cytokines, and this was at 3 months. It was completely clear. So in conclusion, I would say regenerative medicine is rewriting the treatment of osteoarthritis. I don't have any doubt about that. In a few years' time, we will definitely be getting reduction in total knee replacement surgeries. We will be definitely reducing the revision surgeries because the age at which TKRs are being done will be pushed much, much later. Regenerative medicine has ability to target local as well as systemic disease, and that is the advantage. Evidence is building up very fast, but training in regenerative medicine, so it's like another subject completely. So I think it's very crucial to have training so that we get effective treatments and crystallization of treatments. Plus, following strict protocols, I think, is non-negotiable. We are having this conference in Bombay, 5th and 6th September. 7th September is cadaver workshop, which is already sold out. But 5th and 6th, we have a packed scientific schedule, and we have hands-on ultrasound workshop. We have MFAT masterclass. We have PRP masterclass. We have cadaver workshop. We have BMAC guidelines release. And for all of you, I think the most exciting thing is going to be we are going to propose new biological classification of osteoarthritis, in which we are inviting all the collaborators to actually come in and apply it in your clinical practice, and then we can have a consensus kind of thing in a year or two. So, if anyone is interested, please scan this code or visit the website of regionindia.com and get registered. We also do American Board of Regenerative Medicine courses, which are based in Bombay. And we have a diplomat program, which is now running for more than 2 years. We have got more than 100 diplomats qualified till now. We also have a fellowship program. Who all can do these courses? Orthopedic surgeons, of course, pain physicians, plastic surgeons, rheumatologists, gynecologists, dermatologists, internal medicine specialists, immunologists. So any postgraduate doctor who's interested in regenerative medicine, I would really invite them to join us. Thank you so much for patiently listening to me. I hope I could ignite some interest in regenerative medicine.
Thank you, Shamila. It was such an informative talk, and I think people like who are like, now we are like at SOAR, we are also doing lot of things as a society of osteoarthritis and research. And I think this aspect needs to be really looked at because offering these patients very early, like will not only mitigate the surgical interventions as well as maybe the life becomes very good for them, and especially the goldic treatment for the other autoimmune disease like where
Yeah.
they that also really is very appealing. And I think uh most of the people like in our group also should think about this. Any questions, if anybody has, please can directly interact with Dr. Shamila.
Yeah, so I think there is a question, can we do regenerative medicine in case of elevated ESR and CRP? Yes, we can. There are so many, prerequisites as we go along. If we are having elevated ESR and CRP, of course, we need to investigate whether there is another reason for it. Okay, so is there any deeper infection? So we need to treat that and then come back and say. But if it is indicating only chronic inflammation, of course, we are there to treat that. And so we cannot expect an ideal patient with everything normal to treat. So yes, we can treat. Is Goldic available in India right now? No. We are hoping that it will be available in by 2027.
So how many injections at what interval you do like for a patient like who is having an early osteoarthritis knee? And
So if we are talking, so there are two, three things that we can do. Okay, so PRP could be one, wherein PRP is not regenerative, but it gives superb result to relief to patient, and it is not chondro destructive, so to say. So I think we can do three sessions. That's our protocol. 3 sessions of PRP every third week. We do one session, and our patients have responded extremely well. If our dosing is correct, the response is great. So that is the critical thing.
and how much it costs like in an
Depends on what kits you are using. It is completely up to the practitioner how much they are charging. But we very typically, I'll tell you, in Bombay, we will be charging something around 35,000 per session per kit, like per joint.
And
And
what about the adipose tissue? Like how it is
adipose
injected?
tissue, yeah. So adipose tissue gives much longer term result, and it is truly regenerative also. Adipose tissue, what we have seen is giving around minimum of 5 years or much more. Actually, I
One
have
single
repeated,
injection?
yeah, single injection. I have repeated adipose only in one patient, and that too came after 5 years. I generally do not give adipose, treatment in patients who are more than 70, 72 years old, because their cells won't be so much uh, active, or regenerative potential is less in with advancing age. But that patient whom I had done again was 78 years old, and he insisted to do this. And then after 5 years, he came back saying that now I have pain, and he insisted to repeat it. And I repeated it, and it lasted for 2 years more. So yes, it is giving very long-term results. Typically, depends again on what processor you're using. We are using something which is coming to us from the US. So everything is US based, what we are using. Plus, it is CDSCO approved and FDA approved. It typically, what we charge the patient is around 2.5 lakh rupees, Indian rupees, for two joints.
Okay.
But
And
we use
what
only,
happens
but
like
you
once
have to
the
use only one joint, one processor for everything.
so once the joint is injected, like then they need
Yeah.
to rehabilitate because the muscles
Yes,
and the other thing
absolutely.
around
So, I
the
mean, there are so many things to it. You need to prepare the patient also. So, we put the patient on anti-inflammatory diet at least a week or two before we do the treatments. So, again, all these things help us to get maximum best results. So, more effort you put in patient's preparation, you really see the change in the results. So we do that, and post injection 2 or 3 days, yes, patient does have pain. At least 20% patients will say that they have pain for 3 days or 3 to 4 days. We start the physiotherapy at fifth or sixth day. Most of the times we can start at on fifth or sixth day, and within a month they start actually feeling much relief and much difference. So typically any regenerative procedure, this is my standard line to the patients, it will take time. It will be 1 to 3 months. That's the period that we give, so that they are not disappointed, that I'm still having pain. Sometimes it does take time, but yeah, 3 months has been my maximum of getting relief, good relief. So when I'm saying good relief, it has to be 80-90% of pain relief minimum.
so there are no legal implications in India about PRP and the adipose tissue.
No, not
You
at
can
all.
do it.
Yeah. So these are
Ethical
autologous
clearance and
therapies.
all
Yeah.
that we need to
Now,
take.
so in adipose, I'll tell you what is the difference. Okay, so adipose, what I showed you is microfragmented fat. So you're not changing the properties or of fat or tissue.
Okay.
So that procedure actually is called as fat grafting. So what we are doing is we are just refining the fat. We are washing, purifying, and refining the fat and grafting it in the knee. So incidentally, there are so many cells. So it's not true stem cell therapy there. So there is should not be any legal issue there.
Okay.
Uh, Thank you so much. Anything else anybody wants to ask, please go ahead.
So I think it was such an engaging talk because it's something new and this recent SoulCon, like because of this workshop which I attended by the Dr. Shiva Chala and the other, because he was one of the organizers. He was the secretary for the conference. So and there is person who is going to, I'm just forgetting his name, who is going
Huh.
to present that BMAC guidelines.
Hmm.
अभी आपका
Yeah.
this thing. So he was
I
also
think
there
Madhan
and
must be there. Dr.
yeah, yeah,
Madhan must be there.
yeah,
Yeah.
he was there, and he was we attended one live session like, so there was a bilateral avian of the knee, which was he gave around 40 ml of, he took out 40 ml of bone marrow and then centrifuged and,
Yeah.
then removing the buffy coat and all that, giving the cells. We
Yeah.
saw it like live,
Yeah.
that was so nice. And that really gave us a new hope for a therapy, like where we are, in the initial part. Because when the person is 35 years, 40 years, we really want to, get
Absolutely.
away with the surgery. We don't want to offer them knee replacement because still, like, this is important. So
Yeah.
I hope like should be interested. I have registered, I think, for the conference. मुझे याद भी नहीं because I have to see, but I think I would love
Yeah,
to be
please.
there in
Yeah,
Bombay
please. Yeah, please
and
come.
would love to
I'm
collaborate
seeing
with you.
Dr. Naresh Agarwal sir here. Okay, sir, hello, and he has commented. Thank you so much,
Hello.
sir.
Yes,
Thank you so much.
Dr. Sharmila, you are a great ambassador of regenerative medicine and orthobiologics. There can't be a better person to represent this upcoming science.
Thank you.
You
Thank
have
you so much.
influenced so many in the
Thank you.
fraternity, including me. You are
Oh, thank you. You
responsible
have been
for,
you've been such a
change my,
support, actually.
practice.
Oh my God,
Oh,
that's an honor.
you deserve much more, and it's great. Such simplification in your talk was really the greatest thing because it's not easy to simplify the new and complex subjects. The way you simplified, at the same time, you did not lose the character and scientific background of your talk. That was wonderful. That is
Thank you.
ideal.
Thank you.
Highest international standards, I would say.
Thank you so much, sir. Thank you. I'm very
So
honored.
I think if
Great.
there are no more questions, and I would really appeal to all the SOAR member, and we will keep posting in the SOAR group also to attend that conference. It was so nice, Shamila. I think we will be listening to you more, and I think I'm very much interested to come down to Bombay or to any place where I can do some,
Please, please,
how to learn and go, because
please,
this is really
anytime.
very important and very upcoming science which everybody should understand and know when we are talking about osteoarthritis and now with the changing scenario of the disease also. Thank you
Thank
so
you.
much.
Thank you.
Shabbat
Thank you so
khair.
much.
Good night.
Thank you. Good night. Good night.
Good night, Dr. Kiran.
Good night. Good night, everybody. Good night, Dr. Pooja.